We are live now, ma'am.
Yeah. So we can start.
Yes, ma'am.
Yeah. So Priya, please.
Yes. So a very good evening to all of you, all the respected dignitaries who have come logged in from India and abroad, our international faculty and all the national faculties. This is the fifth. We welcome you to this fifth episode of Indian Society of Perinatology and Reproductive Biology ISOPAP Seed to Bloom series that has been started by Fertility Enhancement Committee of ISOPAP in collaboration with Delhi, Burla, then Patna, Jamshedpur and Agra city chapters of ISOPAP. So, to give the welcome address, may I request Dr. Lakshmi Shrikhande Madam, who is the convener, she is the chairperson of this Fertility Enhancement Committee of ISOPAP, and she is also the convener of this series. So, may I ask you, Lakshmi ma'am, may I have the CV of Lakshmi ma'am, Sahiti?
So Priya, it is displayed.
Is it displayed already?
Yeah. Actually, it was a little bit some issues. So, Madam is the chairperson ICOG, as I said, at present. She has been doing lots of work in ICOG, National Corresponding Editor of Jogi, National Corresponding Secretary, Association of Medical Women India, founder, patron, and president ISOPAV Vidarbha chapter. Then chairperson IMS, president Association of Medical Women Nagpur. Nagpur Ratan Award. She's been awarded by so many awards and even the Bharat Excellence Award. Mehru Dara Hansotia Best Committee Award for her work as chairperson HIV/AIDS Committee FOXY. That is really very prestigious. Received appreciation letter from the Maharashtra government for her work in the field of Save the Girl Child. Senior Vice President FOXY 2012, President Menopause Society in the year 2016-18, President Nagpur OBGY Society in 2005-6. She has delivered 11 orations and 450 guest lectures. You can just imagine. She has got so many of publications, 30 national and 11 international publications to her credit. She has been sensitized 2 lakh boys and girls on adolescent health issues. So, Madam, over to you for the welcome address.
Yeah. And Saiti, let Supriya's slide be there because before I proceed, I would definitely like to introduce Supriya Jaiswal myself. She is the co-convener for this whole Seed to Bloom series. And I must say, my right hand, Supriya, without you, I just can't imagine this series going on so well. And as you all can see, Supriya, she herself is a very, very dynamic person, hardworking, sincere. You give her any responsibility and Supriya will do her best to see that that responsibility is implemented in a perfect way. She is currently Vice President, Patna OBGY Society, Chairperson of FOXY Adolescent Health Committee, Joint Secretary of SAUCY, Bihar and Jharkhand chapter. And as you can see, she is holding positions in so many organizations and doing a wonderful job in all the organizations, and she has special interest in high risk pregnancy and preventive oncology. So Supriya, my special appreciation to you. Now I proceed to my welcome address, and it's my honor and privilege to welcome our national president, Dr. Arup Kumar Maji sir. Sir, I have high respect and regards for you, president elect. My friend, I call her friend only, Dr. Sulekha Pandey madam. बोल देती हूँ, एज में ज्यादा है, पर she is teenager. So Dr. Sulekha Pandey madam, president elect of National ISOPAP, Dr. Hiralal Konar, and our international faculty, Elif. She joined just on one WhatsApp message and she said yes. And there was some communication gap on my side, but I appreciate Elif for joining in and I welcome you. She has joined in from Turkey with so much of time difference. And this is our 5th series. I am missing Pragya. I hope she joins. She is the Secretary General of National ISOPA. And I welcome all my esteemed faculties, Dr. Hemali, Anupam Gupta will log in, Sanjukta Mahapatra, Tapan Patnayak, Dr. Mala Srivastav, Ankita Srivastav, Padmalaya Thakur, Anju Parira, Ruchika Garg, Jayati Malhotra, Sangeeta Singhal. So all the faculties are most welcome. And here I would like to appreciate our this partner, Shield, Sahiti is there. She is there for all our programs and doing the technical work, providing us with the technical support. So I welcome all the dear delegates who have logged in, and today's theme is PCOS and infertility. Because we know that almost 5 to 15% prevalence of PCOS is there, and majority of female infertility patients, they are having anovulation or subovulation as the etiology, and in this category PCO is responsible for majority of cases of anovulation or subovulation. So it is a topic of very practical importance for each one of us who is practicing OBGYN, need not be infertility specialist, because these patients are going to all the OBGYN practitioners. So now, without wasting much time, I am handing over back to Supriya for introduction of our chief guest of honor. Supriya, please proceed.
Yes. Before that, we'll just have a prayer. So, Sahiti, just start with the
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Thank you. So we have our President ISOPA, Professor Arup Kumar Maji sir, who is a professor of Shanti Niketan Medical College, West Bengal. He's author of so many books like Bedside Clinics in Obstetrics, Bedside Clinics in Gynecology, Operative Obstetrics, and so many. Former professor and head OBGY, RG Kar Medical College, Kolkata, President Bengal OBGY Society, President Kolkata Chapter ISOPAB in 1820, Scientific Committee Co-Chairperson of AICOG 2023. That was a great hit. Then 30 years of teaching experience and examiner of UG, PG and DNB of various universities. Sir has nearly 100 publications in national and international journals. Editor of Indian Journal of Perinatology and Reproductive Biology in 2010 to 2017. Past national corresponding editor of Jogi. Sir has a huge CV and he's a teacher of teachers. So over to you, sir, for your words of blessings.
Good afternoon, everybody. After a grand success, 3 days conference, the first ISOPAB conference at Gorakhpur, we have just returned. Many of us there, and some of our also busy with the Foxy conference at Bombay. And now another very important CME organized none other than by the Lakshmi Sekande, the convener and the co-convener Dr. Supriya Jaiswal, the Seed to Bloom series, the episode 5. The chairperson of this is Dr. Lakshmi Sekandari, the Fertility Enhancement Committee. And so can I remember the last episode was in the end of the September, 25th September, and that was also a very important topics on the endometriosis and adenosis. And they have selected, actually this time another very important topic, the PCOS and the infertility. And her aim is to involve as much as possible of the ISOPAR chapters. Today, I am very happy to see the Delhi chapter with us, Bulla chapter with us, Patna chapter with us, Jamshedpur and Agra city chapters, all up are with us. It is very difficult to coordinate and connect all those the chapters and involve all the president, secretary, and other persons. And I am very happy to see there is the international speaker, Dr. Elif Göktuğ Topku from the Turkey. And today we have with us our chief guest, Dr. Sulekha Pandey. Already we have told that is the president-elect of 2024-25 of the ISOPAR. In spite of her several physical hurdles, she has come and she goes everywhere. I am really surprised. And another, our guest of honor, Dr. H.L. Konar, who is the international faculty as well. She was also going to the Juba ISOPAR conference at Gorakhpur, attended, and also the Foxy. So, and really, there are three scientific sessions. One is the PCOS phenotype by the Dr. Elif Göktuğ. The chairperson is from Patna. ISOPAR president Dr. Himel Sinha is also the HOD of the Patna AIMS, and Dr. Anupam Gupta, president Agra chapter. And second session, another is the managing PCOS and infertility. Speaker is none other than our very dynamic and dedicated and very academic. I do not know how she gets time for doing this. The none other than Dr. Lakshmi Sekandre, chairperson, Fertility Enhancing Committee. And the chairing the session is the Sanjukta Mahapatra, President Bhubaneswar, and Dr. Tapan Patnaik, Secretary Bhubaneswar chapter. Moderator of our last panel discussion, none other than Dr. Mala Srivastav. Yesterday we have met at the Gorakhpur, and she is also the Vice President of the Delhi chapter. Dr. Ankita Srivastav is also from Delhi. And the panelist, the eminent panelist is Paddala Thakur from the Assume Hospital, Bhubaneswar, Unju Patra, President, Bokaro chapter, Sangeeta Singhal, President, Jamshedpur, Jyoti Malhotra, Secretary, Patna, and Ruchika Garg, Secretary, Agra. Really, it is a very tough job how Dr. Lakshmi and Supriya have connected all those the important and eminent persons of the ISOPAR in this platform. So without going into not so much detail about the particularly the scientific topic, we will hear from all the stalwarts here, wishing a grand success of the CME on PCOS and infertility. Long live ISOPAR. We will enjoy the CME today. Very important topic. Thank you all.
Thank you, sir.
Thank you very much, sir, for your words of blessings and such encouraging words. We had actually Dr. Pragya Mishra, who's the Secretary General of ISOPAP. She couldn't join just from, so we'll just move ahead. She might join in between. So the chief guest, we welcome the chief guest, Dr. Sulekha Pandey, Madam, who is the President-elect, awarded Best Student Award, President of India by the President of India, Silver Medal and Pfizer Gold Medals. So she is the recipient of INSA Fellowship and visited Germany, Fellowship in Maternal Fetal Medicine in Hanover Medical College, Germany, then trained in fetal medicine, Cardiff, UK, and Hospital, London. Actively participate in community service of WHO, UNICEF, NACO, BPNI, and UPASAC. Published more than 70 papers in national and international journals and published several chapters in different books. She was an examiner in more than 15 Indian universities, examiner of National Board of Examination, that is so prestigious, from 2002 to 2020, inspector in National Board of Examinations and also Medical Council of India. She had been an expert in Union Public Commission, New Delhi, and JK, MP, and UP. Awarded Manishi Ratna 2000 award in 2008 and others. So Madam has a huge CV, and Madam, I welcome you and request you to kindly Thank you for being the chief guest of today's program. Kindly bless the webinar today.
Thank you very much, Dr. Supriya. I thank the organizers of Seed to Bloom series of webinar, and the Patna Isopap Society is very dynamic, especially Dr. Supriya. And my special thanks to Dr. Lakshmi, who had been a very close friend of mine for the last many, many years. My special thanks and regards goes to all the members and office bearers of National Isopath Society, Dr. Arup Machi, Dr. Kunar, Dr. Pragya, and my work has been very easy now because all the names Dr. Arup has already mentioned. So without wasting much time, I want to thank our international speaker who has devoted so much of time, and she is going to speak on a very important topic, polycystic ovarian syndrome. And without wasting our time, I would like to listen to all the speakers who are there, and I welcome the speakers and thank them for devoting the time, and I congratulate Supriya and Lakshmi for their hard work and the success they have done. And thank you very much. So please, you can go ahead.
Thank you. Thank you, madam.
Thank you, madam, for your blessings. Now, we are fortunate to have as guest of honor Dr. Hiralal Kunar sir. Sir is the advisor of Scientific Committee AICOG 2023 Kolkata and the chairperson of Indian College of Obstetricians and Gynecologists in 2013, vice president FOXI 2008, ISOPAP 2022. He had held many posts like president in Bengal OBGY Society, national corresponding editor of Jogi, editor-in-chief of Journal of ISOPAP, then FOXI representative to that is AOFOG. I am member of Oncology Committee of AOFOG. He is a real writer and author. He has textbook of obstetrics, textbook of gynecology, clinics in obstetrics, clinics in gynecology, and publications more than 106 journals. GMA, Junior Journal of Obstetrics and Gynecology of India, AGOG, TOG, JOGR. So he has got many publications to his credit. He is also the teacher of teachers. So with these words, I welcome you, sir, Dr. Hiralal Kunar sir, for your words of blessings.
Good evening, everybody. Thanks, Dr. Jaiswal, for the kind words of introduction. We are so happy to join this CME Seed to Bloom series organized by our good friend Dr. Lakshmi Sekhande, the chairpersons of the Fertility Enhancing Committee of ISOPAP, to acknowledge all our stalwarts, Professor Majhi, Pragya, Professor Pandey, and myself and Supriya. This is a great occasion that the names of the speakers have already been told. The PCOS has been divided into all the groups like of that of the phenotype of PCOS and that of the managing PCOS and infertility. And again, then the panel discussion comes with that of under the coordinatorship of moderatorship of Dr. Mala Srivastav, the Vice President of North Zone, with her team. And it's a great occasion to learn all this. As you know, the ISOPAP is progressing aggressively in all field of academic and social different activities. And this topic definitely that Dr. Lakshmi has selected is bit of dynamic research these days. You know, it is a heterogeneous condition, multifactorial, polygenic, and condition that we are exploring many areas of this disease pathology, apart from that of the infertility problem and that of the delayed conception, even the pregnancy problems in terms of miscarriage, even the health problem of obesity, and ultimate outcome of the metabolic abnormality of insulin resistance, and that of the many other areas of even the cancers in the body, the endometrial cancer, all are there. So we are especially would be interested to listen to this problem of infertility. And we have got the privilege of an international speaker, Dr. Elif from Turkey. We need to know the situations all over the world. And our good friends are there, Dr. Himali, Dr. Anupam Gupta from Agra, Dr. Tapan from Bhubaneswar, Dr. Madam Sanjukta, obviously the Delhi team, all the societies of the 5 chapters of ISOPAR, Delhi, Burla, Patna, Jamshedpur, and Agra all have been involved. It's a great occasion, great evening. I wish all the program success. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thank you. So now we start with the scientific session. And to begin the scientific session, we have the first session where the speaker is none other than our international speaker, Dr. Elif from Turkey. We are eager to hear her, and to chair the session, we have Dr. Himali Sinha Madam, who is at present the president of Patna Society of ISOPAB, and she is the professor and head of obstetrics and gynecology AI AIMS Patna. Professional interest, she has got more in maternal fetal medicine, social obstetrics, epidemiology, and preventive oncology. She is the WHO fellow in high-risk pregnancies in AIMS New Delhi, WHO fellow in epidemiology and medical statistics, London School of Hygiene and Tropical Medicine, UK, master trainer EMOC, BMOC, SBA and IPAS, publications in national and international journals. She has been contributing chapters to several books and co-edited Prognosis and Treatment in Obs and Gynae, and she undergraduate and postgraduate examiner, member expert group on preparation of guidelines, MOHFW, that is very important, chairperson clinical research committee of Patna OBGY Society, advisor to so many boards of National Board of Examination in Delhi. So madam is a great teacher. She is a wonderful human being. Welcome you, Himali madam.
Thank you. Thank you, Priya.
Dr. Anupam Gupta, the next chairperson. We have Vice President FOXI 2015. He was a chairperson International Academic Exchange Committee of FOXI in 2010 to 12. Joint Secretary FOXI 2008. Past chairperson UP chapter of SR. Past President Agra OBGY Society in year 2019-21. President Agra chapter in 23-25. And he has held many posts, executive committee member of IFUMB, director Akansha Test Tube Baby Center, and Kusum Gupta Nursing Home, Agra, visiting consultant to various IVF centers at Dehradun, Bareilly, Allahabad, Gorakhpur, and Yamuna Nagar, etc. So I welcome you, sir, Dr. Anupam Gupta, to chair this session. And now I hand over the session to the chairperson, and may I request Dr. Himali Sinha, madam, to kindly introduce our international speaker.
Thank you, Supriya. Good evening, everybody. It's my privilege to introduce our first speaker today, Dr. Elif Göknur Topku. She's a fellow in reproductive endocrinology and IVF at Maslak Hospital, Istanbul, Turkey, since August this year. After completing medical studies at the Marmara University, she underwent specialty training at the training in the research hospital at Istanbul. She has undergone 1 year of clinical and research fellowship in maternal fetal medicine in the University of Maryland, USA. She's the immediate past president of World Association of Trainees in Obstetrics and Gynecology and past president of the European Network of Trainees in Obstetrics and Gynecology. I welcome you, doctor. And she will be speaking on PCOS phenotypes, outcomes in infertility.
Thank you very much for your kind words, and thank you to the organizing members, especially Dr. Lakshmi, and for invitation. It's a great honor and pleasure to be here today. I'm going to open my slides. Okay, I hope you can see it. So I'm going to talk about PCOS phenotypes and outcomes on infertility today. My presentation flow will be about general information on PCOS. What are the PCOS phenotypes? How do we classify these PCOS phenotypes? Are there long-term consequences and short-term and fertility consequences for PCOS phenotypes? So, as we all know and already thought about, PCOS is a very common syndrome with a prevalence around 10%, and it's a common cause for infertility in the reproductive age group. And it's a complex disorder. It can cause reproductive abnormalities, marked insulin resistance, increased risk of type 2 diabetes, coronary heart disease, dyslipidemia, cerebrovascular morbidity, and anxiety and depression. And if the patient gets pregnant with the PCOS, there are increased odds of gestational diabetes, preeclampsia, marcosomia, SGA, and prenatal mortality. And we know that the hospital admissions for women with PCOS are twice as high as for the general population. So how do we classify PCOS? There are several classifications, and the most up-to-date one that we use are the modified Rotterdam criteria, which constitutes, there are 3 criteria, and 2 out of 3 is required to meet the PCOS criteria. One of them being hyperandrogenism, other one is the ovulatory dysfunction, can be oligo or anovulation, and the last one is the polycystic morphology on ultrasound. So in the extension of the ASHRAE phenotypes in 2012, now we have the required criteria plus the phenotypes. So we're going to go one by one with the criteria and how these can affect women. So the first one is hyperandrogenism. It is a defining feature of women with PCOS, and due to disruption of the normal ovarian and adrenal function, there's a production of excess androgens. And with these increased androgens, there's a dysregulation in the neuroendocrine system. As we all know, it ends up with increased hypothalamic GnRH, which causes more increase in the LH beta subunit than the FSH subunit. And this classically, the hormonal hallmark of PCOS, which is the increased LH-FSH ratio. Also, the increased LH causes, it affects mostly the arrested parenteral and enteral stages of the follicles, and it causes hyperplasia of theca cells and accumulation of follicular fluid, which ends up with the pearl-like appearance in the ultrasound that we see, and we call the PCO morphology. As the doctors already shared, we still don't know, and we're still doing research on the etiology of PCOS, as well as the hyperandrogenism within. There are several studies that links to genetic or clinical heterogeneity, maternal inheritance, expression of different genes, and exposure of the fetus during in utero, and also maternal nutrition and epigenetic changes. But as we also mentioned before, there's still need of research to determine what causes the reason. And hyperandrogenism can be seen both either clinical or biochemical, such as hirsutism or acne in clinical, or the increased to free testosterone levels in biochemical. So the Monash University suggests that to assess the biochemical hyperandrogenism in the diagnosis of PCOS, we can either use the calculated free testosterone, free androgen index, or the calculated bioavailable testosterone in meanwhile. So going to the second criteria is the ovulatory dysfunction. 95% of PCOS patients either have oligomenorrhea or amenorrhea. And we all know that up to 32% of the cycles in PCOS patients may ovulate spontaneously. And these cycles can be more regular later in life when we get closer to menopause era. But we also know that the amenorrheic women with PCOS are the ones who have the most severe hyperandrogenism and higher AFC levels. Going to the third criteria is the PCO morphology that we just discussed, that we can see on the ultrasound due to the increase in the LH, the pearl-like morphology. To define this, we know that the patient has to be after 8 years of menarche or age more than 20 years. And the morphology, we can see either more than 12 antral follicles in one ovary, between 2 to 9 millimeter follicles, or more than 10 centimeter cube ovarian volume. So after discussing the criteria, let's go into PCOS phenotypes. We have 4 different phenotypes, A, B, C, and D. So phenotype A is the full-blown syndrome of PCOS. It means the 3 out of 3 criteria: hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. If we see all 3 of these criteria, then we call them phenotype number A. Phenotype B is non-PCO PCOS. We have the hyperandrogenism, we have the ovulatory dysfunction, but we don't have the PCO morphology on the ultrasound. Phenotype C is the ovulatory PCOS that has the hyperandrogenism, has the polycystic ovaries morphology, but they ovulate every month. And phenotype D is the non-hyperandrogenic PCOS. There's ovulatory dysfunction, there's polycystic ovaries, but we don't have hyperandrogenism in these patients. Here in the table, we can see how the phenotypes are and what do they have in respective to each other. And these are important to know because these can have different effects on fertility. And here we can see the polycystic ovarian syndrome phenotypes in decreasing clinical severity from phenotype A to D. So what does this mean? The full-blown PCOS phenotype A is the most common phenotype. The prevalence is around 60% in PCOS patients. But when we look at the clinical populations that were identified, we see phenotype A more common. But when we look at the unselected population, the phenotype C is more common than phenotype A. And this is a paper from my country in Turkey. So what are the differences in phenotype A? As we said, it's the full-blown type. We have increased obesity, hyperandrogenism, insulin resistance, deranged lipid profile, metabolic syndrome, and adverse metabolic and cardiovascular outcomes. In the reproductive, in the young age, we see more reproductive disorders. We see menstrual disorders, infertility, which is our topic today. And as women get older, we see the increase in metabolic diseases, in type 2 diabetes, cardiovascular diseases, etc. So this is a phenotype that affects, and it's a syndrome that affects a variation of ages in women and have different outcomes depending on which year and which kind of problems that you can have during your lifetime. And going to phenotype A to phenotype D, as we said, the effects decrease. So we have lesser effects. We see less obesity, less hyperandrogenism, and less adverse metabolic and cardiovascular outcomes. So going to fertility outcomes of the PCOS phenotypes have their own specific treatment in the impaired fertility and different outcomes. For example, the clomiphene resistance seen higher, more common in phenotype A, and the phenotype D are better responders for clomiphene strut. As we all know that when we look at the metformin and letrozole comparison, this is for all PCOS, that includes 21 RCTs with more than 2,500 patients with PCOS. We know that the combination of metformin and clomiphene strut is associated with lower clinical pregnancy rate than compared to letrozole. And that is why we shifted our medication in subfertility patients or infertility patients to letrozole in PCOS. When we look at the fertility outcomes using gonadotropins in PCOS, we have a challenge because due to hyperandrogenism, we can have insufficient effects using gonadotropins. And if we use increasing dose, then we can have hyperstimulation. And this is also correlated with the BMI and AMH levels. And when we look at the risk of OHSS, we choose more antagonistic protocol in PCOS patients, and we use GnRH agonist rather than ACG trigger. And we tend to use freeze all and cryopreserve our patients and plan the embryo transfer in the next cycle so we don't have hyperstimulation signs. And diving into the phenotypes, we know that the PCOS phenotypes A have higher AMH levels. And we did say that the higher AMH levels can have more abnormalities as a phenotype A, and aldosterone levels can differentiate. That is, we know that phenotype A have higher than phenotype D, and LH and AMH levels also are higher in phenotype A, and these result with different effects and different outcomes in fertility. So hyperstimulation syndrome, we see phenotype A and C. As we remember, they're both have hyperandrogenism and PCO morphology. They have higher risk of hyperstimulation. So phenotype A, it requires longer duration of stimulation. There's risk of higher response and risk of hyperstimulation. When phenotype B, where we don't have the PCO morphology, we have lower risk of hyperstimulation, as we can understand why. There's also a higher risk of miscarriage that we can see in the literature. When the BMI and insulin resistance is higher, then there's increased risk of spontaneous abortion in PCOS patients. As we said, this also differentiates between PCOS phenotypes, since phenotypes A and B and D have higher hyperandrogenism than phenotype C, which is the ovulatory PCOS, then they have higher risk of miscarriage. And the risk of spontaneous miscarriage after IVF is higher in phenotypes A, B, and C rather than D. Here we see another publication on how the PCOS phenotypes impact oocyte morphology. There are different publications due to these morphologies in this paper. That was published in 2022. They found differences between aldosterone, LH levels, and AMH levels, as not a surprise, higher in PCOS-A. But here they did not see any difference between number of ICSI cycles, dose of FSA gonadotropins, or they did not see any difference between oocyte quality between PCOS phenotypes. But this is not the same in other research. There is another research that was published in 2018, and they did find that the PCOS phenotypes with higher hyperandrogenism had lower cumulative live birth rates. They looked at 567 women with fresh embryo transfer, and the cumulative live birth rate for phenotype A was 25%, while for phenotype D, it was 48%. Another research also concludes that the oocyte health depends on PCOS phenotypes and comorbidities associated with, as we said, the PCOS and higher BMI can have negative effect on oocyte health, and hyperandrogenism and chronic anovulation can have negative effect on cumulative pregnancy rates. So there's another research from 2017 that they also proved that the full-blown PCOS have a poor morphologic quality of oocytes, which is a phenotype A, and cardinal features of PCOS, the criteria, have independently or combined have adverse impacts on oocyte quality. So PCOS varies with the oocyte health and largely depends on PCOS phenotypes. And PCOS phenotype B can have poor IVF ICSI outcomes due to the number of oocytes retrieved. As we know, this is the one with the doesn't have the PCO morphology. And it has been said that the PCOM, so the ultrasound PCO morphology, carry an advantage on number of oocytes retrieved and better quality embryos. And we can see that also in our clinical work. And so when as we said, if the PCO, we don't have the morphology, but we have hyperandrogenism and ovulatory dysfunction, then we have low quality, but the biochemical and clinical confirmed pregnancies and number of couples born with children found not to be different in these patients. So overall, if we're going to conclude them, there might not be a significant oocyte morphological quality, but the live birth and the cumulative live birth rates are better in phenotype D than A. And classical phenotypes, PCOS A and B, have higher obesity, higher BMI, higher insulin resistance, and they have cellular process disorders related to glucose and androgen metabolism, and these have negative effects on gametes and oocyte quality and embryos. If the patient gets pregnant, as we said, there are also negative effects of PCOS phenotypes in pregnancy outcomes. If the patients have higher hyperandrogenism, then there is a higher incidence of pregnancy complications. It has been found that 1 picogram milliliter increase in free testosterone levels in phenotype A and B can decrease clinically confirmed pregnancies by 50 to 60%. And it's a very high rate, and proportion of live births also decrease with an increase of free testosterone levels. There's a higher rate of complications for PCOS patients: miscarriage, OHSS, diabetes, hypertension, preterm birth, and LGA. And there is a meta-analysis that has been made in 2018 that there is an international evidence-based guideline for increased adverse outcomes for PCOS patients. Also, this is an old paper, but still relative to our day, that was published in 2010, Infertility and Sterility. And the paper is Pregnancy in Women PCOS, the Effect of Different Phenotypes and Features on Obstetric and Neonatal Outcomes. We can see here that ovarian dysfunction and biochemical hyperandrogenism can increase the risk of obstetrics and neonatal complications 4 times more than the others. So clinical hyperandrogenism, which is acne, and the other ones, not the free testosterone levels, but the clinical hyperandrogenism and PCO morphology, was found not to have significant effect, just slightly increased adverse outcomes, but the biochemical hyperandrogenism and ovarian dysfunction have 4 times increased risk in obstetric complications and also long-term cardiovascular diseases. So my take-home messages will be: not all PCOS phenotypes have similar metabolic risk, infertility risk, treatment resistancy, and the treatment outcomes, and hyperstimulation syndromes, and adverse obstetric and neonatal outcomes. It's important to know what kind of phenotype does our patient have when we're looking at fertility treatments and outcomes. If our patient has a phenotype A, which is a full-blown PCOS that has a hyperandrogenism, ovulatory dysfunction, and the PCO morphology, it is the most severe type that we have to be more careful of. And phenotype D is the most mild type. And as we just heard, hyperandrogenism is not good for our patients at any age. So thank you very much for listening, and happy to have your comments and questions.
Thank you, Dr. Elif. It was indeed a wonderful lecture from you, and the way you told about the different phenotypes, and that is going to help us counsel the patients better, because when we are able to tell them that what are your prognosis of your disease, so they are better assisted. Thank you so much. It has been really wonderful listening to you. Thank you so much, Dr. Elif.
Thank you.
Himali?
Yeah. Thank you, Dr. Elif. That was a very concise and very well explained. And of course, as Dr. Gupta said, it'll help us, counsel the patient, because sometimes it becomes very difficult. They say the 2 patients with PCOS, they say their results are better. Why is mine not better? So now this will help us counsel if we are able to classify the category of PCOS the patient is, and tailor her treatment accordingly. Thank you very much for this very lucid lecture of yours.
Thank you, Elif. Thank you so much for being with us in India, though virtually. We loved your talk, and it was very, very informative.
Thank you so much for everyone, for our chairs, and for Dr. Laxmi for kind words.
Thank you. And you stay because in the panel you have to give your expert comments. After my talk, we are having 2 case discussions on PCOS. Yeah. And you can give your expert talk after my, comments after my talk as well.
Thank you.
Thank you so much. Thank you. It was a pleasure listening to you.
Anupam, seeing you after long time.
Yeah. I'm sorry, missed your meetings. Something or the other was going on. So this
Yes.
time, in between my nephew's marriage, I decided to spend an hour with you. Thank
Okay,
you.
but now stay connected.
Yeah, I'm there.
Yes. Supriya, let's start with the second.
Yeah. So I thank the speaker of the first session and the chairpersons. Thank you very much for sharing and holding the session so well. It was very informative, Dr. Elif. So thank you. So start with the second session. We have managing PCOS and infertility. So to chair the session, we have Dr. Sanjukta Mahapatra. Madam is retired professor and HOD OBGY Institute of Medical Sciences of Some Hospital, Bhubaneswar, Odisha since 2007 to 2018. So previously working as professor of OBGY at Navodaya Medical College, Raichur from 2001 to 3, senior specialist in Ministry of Health, Kingdom of Saudi Arabia, 1992-1999, worked as cancer surgeon in Regional Cancer Institute in Qatar, India for 3 years. She has got total medical service experience as a faculty since 37 years. So present president of ISOPA Bhubaneswar chapter, past president Bhubaneswar OBGY Society. Madam has worked in so many associations. And then Foxy member since 1981, life member of IMN ISOPA. Book publications, she has got many, like Narika स्वास्थ्य and माँ का किटोजी. Madam, आपका बहुत अच्छा books है. All beautiful articles written by you. So with this CV, I welcome you to the to chair the session. The next chairperson is Dr. Tapan Patnaik. He is Secretary Bhubaneswar chapter of ISOPAB and Assistant Professor Department for OBGY at Institute of Medical Sciences and Some Hospital, Bhubaneswar. He is a very active member of ISOPAB and had done a wonderful conference of ISOPAB. So welcome to both of the chairpersons.
Already introduced. You just skip that slide. Yeah, they can give.
But she would like to tell something, madam.
Yeah, they can give opening remarks. Yeah, before my talk. Yes.
Dr. Sanjukta, madam, over to you. Just
Namaste.
unmute yourself. Yes.
Okay, thank you very much and namaste to all of us, all of you. And really, I am honored when Dr. Joshua invited me for this session as chairperson. And all of you, all of us know Dr. Lakshmi Srikhande. She is a very active member of ICOG, our Foxy, our ISOPA, everywhere. So nothing to say much about her. Everybody knows her. And this topic also everybody knows, because now in gynecology, 2 topics are more important. Leave aside many. One is PCOS or PCOD, other is endometriosis. And all infertility, most of the infertility cases, patients living male factor, females are suffering from either PCOS or endometriosis. What I see, my experience. And patients are coming for infertility many. I don't know why. I am not a IVF specialist, but ordinary GP. So they are coming and I notice many have this. So I always blame this junk food and obesity. And I scold them. Anyhow, Dr. Elif has told many things about PCOS phenotype. And I hope Dr. Lakshmi Srikhande will speak us, enlighten us with another many things, because he is a very good, eloquent speaker, and she will enlighten us. And all the I see Dr. Arup Maji, Dr. Hiranal Kona, all I know them because they are frequently coming to our institution as guest speaker, lecture, as examiner, as MC, as inspector also. So thank you all, and let us introduce Lakshmi Srikhande.
Dr. Sanjukta, so I will start. Thank you for your opening remarks. So, friends, Elif has made my job very easy. I am going to give you a broad outline how to manage a patient of PCOS when she comes to you with infertility. But first, let us know what this PCOS is all about. I know we all are very well aware that it is a genetic, hormone, metabolic, and reproductive disorder that affects women, and it is the leading cause of female infertility. It can lead to lifelong complications. That is my last slide, because that is also very, very important, because we have to understand the long sequelae along with the psychosexual function which gets affected because of PCOS in the form of anxiety, depression, and their sexual life. So it affects 1 in 10 women. 10 to 15% of women are estimated to have PCOS. 50% of these women, they remain undiagnosed. 50% women with PCOS who will develop type 2 diabetes before the age of 40 years. This should be known to each and every gynecologist. 13.8 billion is the estimated annual cost. Of course, this is the American statistics, and there is 3 times increased risk of developing endometrial cancer if this woman is having PCOS. We all are aware about the common signs and symptoms with which these patients come to our OPD. Coming to the infertility, remember, it is the biggest cause of infertility in women, but at the same time, not all women with PCOS, they will experience infertility. However, it remains the primary cause of anovulatory infertility. So these are the main reasons, causes of female subfertility, and you can see ovulatory disorders constitutes to the 40% of the causes for female subfertility. And in this ovulatory disorder, PCO is the etiological factor for 85% cases of ovulatory dysfunction. PCOS, it is one condition where people always like to agree to disagree. Over the years, these disagreements have continued. Criteria for diagnosis keeps on changing. Management guidelines also keep on changing. So I will be covering the diagnosis, the lifestyle interventions, first line management, second line management, and third line management of infertility in these cases of PCOS. Now, these are the criteria we all are very well aware of, like NIH criteria, the Rotterdam criteria 2003, and the criteria given by Androgen Access Society. Now, currently, what we are following is the guidelines given to us by International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovarian Syndrome, released in ISHRE conference way back in 2018. What is the difference? Not much of a difference. These guidelines endorse the Rotterdam PCO diagnostic criteria in adults. That is, 2 of the clinical or biochemical hyperandrogenism, ovulatory dysfunction, or polycystic ovaries on ultrasound. Difference is where irregular menstrual cycles and hyperandrogenism are present. These guidelines are highlighting that ultrasound is not necessary in diagnosis. But this is for those women who have not come to us for infertility, because for infertility anyway we are doing a day 2 transvaginal scan. This is mainly for the adolescent PCOS. And for the adolescent PCOS also, within 8 years of menarche, both hyperandrogenism and ovulatory dysfunction are required, and ultrasound is here not mandatory. However, in these guidelines, ultrasound criteria have been tightened with advancing technology, and they are saying that AMH levels are not yet adequate for diagnosis, again, more so in the context of adolescent PCOS, because for infertility cases, we are going ahead and doing anti-Mullerian hormone for these patients. So what are the ultrasound criteria which has been given in these guidelines? They have mentioned that you have to do ultrasound with an endovaginal ultrasound with a frequency bandwidth of 8 megahertz. The threshold for PCM should be on either ovary, a follicle number per ovary of equal to or more than 20, and or an ovarian volume of more than or equal to 10 ml, ensuring that you are not including corpora lutea, cyst or dominant follicles in your measurement. So this ovarian volume is more important in cases of adolescent populations where we are reluctant to do a transvaginal ultrasound. If you are using the older technology, the threshold for PCOM could be an ovarian volume of more than or equal to 10 ml on either ovary. So just remember these ultrasound criteria. Guidelines have also highlighted the protocol for reporting the follicle number when we are doing our transvaginal ultrasound. We have to mention all these points in our report. Now, what not should be done? We no more do LH levels, LH-FSH ratio. Fasting insulin is also not sensitive, and we don't use dexamethasone therapy because it can induce insulin resistance. So now coming to the management. If she has come to you with oligomenorrhea and infertility, of course, you have to exclude all other etiologies. If you are sure that she is having PCOS, you have to screen for diabetes and you have to intervene if the HbA1c is more than 6.5, that is the cutoff. You have to consider metformin if HbA1c levels are elevated. I have already told you the cutoff is 6.5. You have to also screen this woman for hyperlipidemia and hypothyroidism. Remember, the cutoff of TSH here is 2.5. Again, the second most important point here is optimizing lifestyle and grab this opportunity for routine prenatal counseling and vaccination. If obese woman with PCOS is coming to you, then weight loss, I will highlight how you should advise her. If BMI is more than 27, then you have to consider weight loss in your strategy. Routine infertility evaluation should be conducted. You have to evaluate her for tubal patency. You have to evaluate the endometrium and don't forget to evaluate the male factors as well. If then you come to a conclusion that she is having infertility because of oligo-ovulation, then you have to initiate with your ovulation induction. So this is the algorithm which will come as a ready reckoner in your day-to-day practice. Now there are other factors which affects fertility, your treatment response or pregnancy outcome. And what are these factors? Just to give you some examples, like you have to do blood glucose, weight of the patient, blood pressure, ask history of smoking, alcohol, ask history of diet, exercise, more so if she is an obese, about her sleep pattern and mental health, about her emotional and sexual health, because all these things have to be optimized so that you can have a good outcome as far as the reproductive and obstetric outcomes are concerned. So once you start, you are there with your diagnosis of oligonovulation. These guidelines are emphasizing more and more on lifestyle intervention. So you can see in this chart that the first line, non-pharmacological management for infertility in PCOS is lifestyle management. Then the first line, pharmacological management, is in the form of letrozole, clomiphene citrate, clomiphene plus metformin, metformin alone, and gonadotropins. Second line, pharmacological / surgical, I have written because second line therapy can be in the form of gonadotropins or laparoscopic ovarian drilling. And the third line management is your ART, that is IVF-ICSI. So now let us start. What do we mean by lifestyle interventions? Because everybody is saying lifestyle, lifestyle, lifestyle. So what do we mean actually? So lifestyle interventions include behavioral strategies, dietary intervention, exercise intervention, and obesity and weight assessment. So what should be the goal setting for weight loss? I know it is very easy for us to tell the patient that go and lose your weight, but we have to guide her how to lose that weight. So for this, you have to give her a SMART goal. And what is this SMART goal? It has to be specific, measurable, achievable, realistic, and timely. So what is the SMART goal? That is 5 to 10% of weight loss in those patients who are obese is considered as successful weight reduction, and this has to be reduced within 6 months. So this should be the SMART goal for weight loss for your PCO patient, that is 5 to 10% of total weight loss in 6 months of time. Now, how to lose weight is the next question. Here comes the role of diet and exercise. Now the internet is flooded with so many types of diet plans. So now the patient is asking you, doctor, which diet plan is best for me and how much calorie deficit you will prescribe for me. So I know if it is suitable to you, if it is convenient, involve a dietitian to prepare a dietary chart for them. But if you are in a remote place or you don't have that facility, then in a nutshell, you have to guide these women about the dietary intervention as well. So what is this dietary intervention? First and foremost, tell her that no dietary type is recommended in PCOS. She should not go on the net and follow those dietary patterns. To achieve weight loss in those who are having excess weight, an energy deficit of 30%, that is 500 to 750 kilocalorie per day, could be prescribed for women, but you have to consider the individual energy requirements, her body weight, her food preferences, and physical activity level. So it has to be an individualized approach. Now, from diet, because diet alone is not going to help her in weight loss, it has to be combined with exercise. So how much exercise for mild weight loss and how much exercise for moderate exercise? And of course, not this kind of exercise which everyone is fond of doing in front of TV. So now again, you have to give her a goal for physical activity. Again, it has to be a SMART goal. So what is this SMART goal? Again, specific, measurable, attainable, relevant, and time-bound goal. So this goal could include 10-minute bouts, progressively increasing physical activity by 5% weekly, up to and above the recommendations what you are giving her, recommending for that particular woman. In those women, a minimum of 150 minutes per week of moderate intensity physical activity. These are all given in guidelines, or 75 minutes per week of vigorous intensities, or an equivalent combination of both, including muscle strengthening activities on 2 non-consecutive days per week. This is for mild weight loss. An activity should be performed in at least 10 minutes bouts or around 1000 steps, aiming to achieve at least 30 minutes daily on most days. But what about moderate weight loss? For moderate weight loss, a minimum of 250 minutes per week of moderate intensity activities, or 150 minutes per week of vigorous intensity, or an equivalent combination of both. And this has to be combined with muscle strengthening activities involving major muscle groups on 2 non-consecutive days per week, and minimize your sedentary screen or sitting time. Of course, when it comes to moderate weight loss, you have to take the help of a gym instructor and of course a dietitian as well. Is there any role of anti-obesity agents? Because a lot of patients, they are looking for a shortcut. They will tell you, doctor, please prescribe a pill so that I can lose weight faster. So what is the recommendation by these guidelines? Pharmacological anti-obesity agents, they could be considered an experimental therapy in women with PCOS for the purpose of improving fertility, with risk to benefit ratios currently too uncertain to advocate these as a fertility therapy. So these are the guidelines as far as the role of anti-obesity agents are concerned. Is there any role of bariatric surgery for these very obese women who come to you for PCOS? Remember, bariatric surgery again is considered as an experimental therapy in these women with PCOS for the purpose of having healthy baby, again with risk to benefit ratios currently too uncertain to advocate this as a fertility therapy. So no shortcut, she has to go for diet and exercise. But if at all bariatric surgery you feel that is needed, you have to consider the following points. You have to recommend her to avoid pregnancy during periods of rapid weight loss and for at least 12 months after bariatric surgery with appropriate contraception. If pregnancy occurs, awareness and preventive management of pre and post-operative nutritional deficiencies is very, very important, ideally in a specialist interdisciplinary care setting. And monitoring of fetal growth during pregnancy has to be very, very stringent. Is there any role of inositol in this type of woman? So again, these are the guidelines recommendation that inositol in any form should currently be considered as experimental therapy in PCOS with emerging evidence on efficacy highlighting the need for further research. But in our day-to-day practice, as it has a very high safety level quotient, we all are giving as an empirical therapy the myoinositol to these type of women. It is one of the therapeutic alternatives which has recently been investigated. It definitely improves the metabolic profile of PCOS patients. There are 9 different stereoisomers of inositol, and D-chiroinositol is the second common isomer. Administration of D-chiroinositol has been proved to reduce insulin resistance, and some studies report that the dose needed is 1 gram D-chiroinositol plus 400 microgram of folic acid per day to reduce the metabolic syndrome and to increase the glycemia insulin ratio. So if at all you want to prescribe, you should know which dose and what combination to be prescribed to this category of women. Now coming to the psychosexual function. All health professionals, they should be aware of the increased prevalence of psychosexual dysfunction, and they should consider exploring how features of PCOS, including hirsutism and body image, is impacting on her sex life and her personal relationships. If psychosexual dysfunction is suspected, there are various tools such as the female sexual function index which can be considered. But as a clinician, first you have to be aware of this entity. Now, should you do tubal patency test in each and every case of this PCOS and infertility? The guidelines are recommending tubal patency test for women with PCOS due to anovulation alone. With normal semen analysis, you have to consider the risk, benefits, cost, and timing of patency should be discussed on one-to-one basis. It should be considered prior to ovulation induction in women with PCOS where you are suspecting tubal infertility. So it's not a must that you should do a tubal patency evaluation in all these women. Now, once you have done all these things, then you have to proceed for the ovulation induction. Don't jump to ovulation induction the moment you see a case of PCOS and infertility. Now, what are the ovulation induction principles? Because they are having irregular cycles, remember to exclude pregnancy prior to your ovulation induction, prior to giving them withdrawal bleeding, so that you can start your day 2 ovulation. Unsuccessful, prolonged use of ovulation induction agents, they should be avoided in these cases due to poor success rates. So these are the first line management: letrozole, clomiphene, metformin, metformin in combination with CC and letrozole. Letrozole, it should be started in a dose of 2.5 to 5 milligram from day 2 onwards. You have to start monitoring from day 8 onwards, and there are definite advantages of letrozole over clomiphene citrate in the form of there is no anti-estrogenic effect on endometrium and cervical mucus. You have a monofollicular development, and there are reduced chances of OHSS and multiple pregnancy. Clomiphene citrate again should be started from day 2 if at all you are planning to start clomiphene. The maximum dose you should never exceed beyond 150. Follicular monitoring is same as that of letrozole. And how many cycles? With oral ovulations, I will say not only clomiphene, with oral ovulations, the optimum chances of her becoming pregnant is first 3 to 4 cycles, and you should not do more than 6 cycles of stimulation with these oral ovulations. So when to stop should be known to each and every clinician. When 6 ovulatory cycles fail to give you a pregnancy, there is no ovulation with highest permissible dose, and when endometrial thickness remains less than 7 millimeter, you should stop your ovulation induction protocol. When to add metformin to these agents? When those women who are clomiphene citrate resistant, where BMI is more than 25, and here the aim of adding metformin is to improve ovulation and pregnancy rate. Can you give metformin alone as an ovulation induction agent? Can be given in women with PCOS. However, we don't prescribe it on a standalone basis. It is always combined with CC or letrozole. When you are adding metformin, you should be aware of the following points, that is the GI side effects. For these you have to start it in 500 milligram increments, and this increment should take place 1 to 2 weekly time. Metformin does cause low vitamin B12 levels, so should be aware of it, and it is generally a off-label drug. Now we are having sustained release formulations available which give less GI side effects, so prescribe metformin SR formulations. Now coming to the second line. Second line is gonadotropins or laparoscopic ovarian relay. When to start second line? For those women who failed to conceive with the first line. When gonadotropins can be first line? See, here I am saying second line, but gonadotropins can be your first line therapy in these PCOS women where it is available and affordable, where there is presence of ultrasound monitoring, and where following counseling on cost and potential risk of multiple pregnancy. When you are thinking of gonadotropins as your ovulation induction agent, you should consider the cost, availability, expertise required for use in ovulation induction, degree of intensive ultrasound monitoring required, risk and implications of potential multiple pregnancy, and risk of OHSS. Now market is flooded with so many preparations of gonadotropins. So which gonadotropin? Whether you should use HMG, highly purified HMG, urinary FSH, highly purified FSH, or recombinant FSH, there is no difference. You can simply go ahead and use HMG for your PCO woman. What should be your starting dose? It depends on the age of the woman. Antral follicular count, which you all should learn. You should do your own day 2 transvaginal scan, and antimalarial hormone levels. If she has already undergone gonadotropin cycle, then what was the response in that previous cycle should also be taken into consideration. Just to simplify your life, this is the starting dose for non-IVF I am talking. So it can be started if she's less than 35, non-PCO 150, and if she's PCOS, you can start with 75. But if she's more than 35 years, you can have your starting dose of gonadotropins as 150. Now, how to monitor is a big question. So how you are giving gonadotropins? Starting from day 2. Day 7, you have to call her for transvaginal ultrasound for the dose adjustments. And what you are looking on day 7 transvaginal ultrasound, you are looking for follicles of more than 10 millimeter. If there are 2 to 3 follicle, same dose. 4 to 6 follicle, you can continue with the same dose, or you have to taper. But if there are more than 6 follicles, do taper and look for OHSS. But if their follicles are less than 10 millimeter cycle, you have to increase the dose. When the lead follicle is 18 millimeter, you have to trigger for ovulation. Many would like to combine oral ovulogens with gonadotropins. So how to go ahead with it? From day 2, you have to start your oral ovulation. From day 5, you have to add gonadotropins, and from day 7 onwards, you have to continue monitoring as I showed you in my previous slide. When you are monitoring, don't look at only the follicular size. You have to monitor the endometrial thickness as well. So the number and size of follicles and pattern and thickness of endometrium should be monitored. When to give trigger? If it is an oral ovulation cycle, then the follicle size should be between 20 to 22 millimeter. If it is a standalone gonadotropin cycle, the follicle size is between 18 to 20 millimeter. You can give trigger. What should be the dose? 5,000 IU of SCG is sufficient as a trigger dose in these women. When not to give trigger is also very, very important. When you are seeing 3 or more than 3 lead follicles, you should not give trigger. You should write and document on file that this cycle has been cancelled and advise abstinence to these couples. Now don't forget the luteal phase. When it is a oral ovulation cycle, it is empirical. We all are giving empirical, but evidence is telling us that luteal phase support is not mandatory in cases of oral ovulation cycles. But if it is a gonadotrophin stimulated cycle, then yes, luteal phase support is a must. So you have to give luteal phase support. Various drugs are available. We have oral, intramuscular, or vaginal. It depends, but we do prefer vaginal route of progesterone support as a luteal phase support in majority of the cases. Now coming to the PCO drilling, which is a second line management in these women. This is a surgical solution for a medical problem. It reduces hyperandrogenism and improves the intraovarian milieu, but it lacks standardization in terms of indications, modality, and follow-up. Which PCOS women will benefit from PCO drilling? It is best for those women if they are having infertility duration of less than 3 years, they are thin, lean with high LH levels. Although it has been utilized for decades, the technique has never been standardized regarding the energy source, number of punctures, dose and duration per puncture, whether one or both ovaries should be treated. But based on limited dose ranging studies, 3 to 6 punctures per ovary at 40 watt setting for 4 seconds per puncture seems reasonable. When LOD can be considered as a first line in these women? It can be considered as a first line if anyway laparoscopy is indicated for another reason. Risk should be explained to all women with PCOS considering laparoscopic ovarian surgery, and all lap for infertility should always be combined with hysteroscopy. So these are the advantages of laparoscopic ovarian drilling over gonadotrophin stimulation, and there are disadvantages as well. Now coming to the third line management. Again, you have to consider the availability, cost, convenience, increased risk of OHSS, insufficient evidence to recommend specific FSH preparations. Here also you can safely go ahead and use HMG preparations, and exogenous recombinant LH should not be routinely used in combination with FSH. Which protocol? It has been fairly standardized now. For all these women of PCOS, if they are undergoing IVF, it has to be an antagonist protocol, agonist trigger, and freeze-all embryos, so that we all are having now OHSS free clinic for all our IVF cycles for PCOS patient. But OHSS can occur in cases of oral ovulations and in gonadotrophin cycle as well. So each and every clinician who is managing these women should know about the OHSS, not only IVF and ART clinicians. You should know about the early OHSS and late OHSS. Early presents 3 to 7 days after HCG administration, and late OHSS presents 12 to 17 days after HCG administration. Prevention is better than cure. IVF, we are very much comfortable with our protocol, antagonist protocol, agonist trigger, and freeze-all embryos. In your IUI cycles, you have to avoid SCG. I have already told you when not to give trigger, be liberal with cancellation of cycles. Now here your duty does not end. You should remember that maternal these cases in pregnancy, they have increased prevalence of early pregnancy loss, as Tofu has already highlighted, gestational diabetes, pregnancy-induced hypertension, and small for gestational age babies. Now, even after giving her a healthy baby, your responsibilities don't end, because you have to counsel her about the late sequelae. She is 7 times more at risk for diabetes mellitus, 4 times more risk of hypertension. She is more prone for dyslipidemias and 3 times more risk of endometrial cancer. So friends, to summarize, first and foremost is lifestyle management, optimize BMH, Then only start with the first line management, that is oral ovulagens. Second line, gonadotropins and laparoscopic ovarian drilling. And third line is IVF, ICSI. Don't forget the special care which they need during pregnancy and the late sequelae as well. Remember, it is not what you give, it is the way you give it. So thank you so much for your patient hearing. And if there are any questions, I am more than happy to answer it.
Can I speak for a minute?
Yes, madam, please.
Yeah, thank you very much, Dr. Lakshmi, for your wonderful lecture. And really, you have covered every aspect. I have only 1 or 2 points to ask you. What is your experience before stimulation if the LH level is very high? And another, those patients of PCOS with high AMH, what do you do?
Madam, high AH per se or high LS does not, our plan of management does not change because she is having high AMH. I am having patients with AMH values of 17, 18, 23. We have to be more alert as far as the risk of OHSS is concerned. But we do give because their threshold, sometimes every ovary is different. So sometimes they just don't ovulate. So we have to give gonadotropin. Sometimes they don't ovulate with 37.5. We do increase to 75. But monitoring has to be very, very stringent so that we don't allow them to go towards OHSS. Yes, Tofu, you want to add? Elif, unmute yourself.
Yes, I do agree. We change the doses in my clinic accordingly with the BMI and if the PCOS, but not with the LH or AMH levels either.
Yes. LH does not, we don't consider, madam, we have stopped doing FSH, LH levels for these PCO cases.
Thank you.
Yes, Tapan,
Thank you.
you want to give yes, your comments.
Dr. Namaste. Very nicely, very vividly, very clearly you have mentioned regarding not to do FSH, LH, etc. Madam. The best thing is that you have mentioned very clearly about a smart way of weight loss because everybody is saying lifestyle modification. But how to modify that lifestyle, nobody knows it clearly. So very nicely, very objectively you have said about the smart way of the weight loss, madam. And clearly also you have mentioned about HbA1c level, TSS level, beyond which we have to treat the patient, madam. And clearly you have also mentioned diabetes, obesity and bariatric surgery. Again, myoinositol, these are all experimental. Step by step, ovulation induction. And when to how to treat OHS syndrome also for basic infertility specialist. I'm going to say basic gynecologist. You have very clearly mentioned, as usual, madam. So thanks a lot for inviting me and Dr. Lakshmi and Dr. Supriya. I really, from bottom of my heart, I say thanks a lot for inviting me. Thank you a lot.
Thank you very much.
Add that these guidelines you all can download on Google. Just type these international guidelines PCOS 2018 and whole PDF will pop out. Just download and go through it and read it. Yes.
But you can send your slides in PDF. I'm going to say in this group also.
Yeah. And this whole PDF you all can download from Google. It is freely available.
Okay, thank you very much. Now we conclude.
So thank you. We come to the end of the second session, and I thank the speaker, Dr. Lakshmi Shikhande, madam, for the wonderful, elaborate talk, covered everything, and also the chairperson, Dr. Sanjukta, madam, and Dr. Tapan. So we come to the end of this session, and we start with the third session, that is the panel discussion, and the moderator is Dr. Mala Srivastava and Dr. Ankita. Dr. Mala Srivastava, she is Senior Consultant and Professor, JIPMER, Gynae Endoscopic and Robotic Surgeon, Sir Gangaram Hospital, New Delhi at present. She is Vice President ISOPAR 23-24 and Past President AOGD 22-21. She has got many qualifications and she has got great area of interest like gynae oncology, gynae endoscopic surgery and gynae robotic surgeries. Madam is Secretary General of NICE, North India Gynecological Forum, awardee of so many awards like APJ Abdul Kalam Excellence Award of this Delhi Gynecology Forum. That is a very prestigious one. She had won long back. Then awardee of Dr. Subhash Mukhopadhyay Women's Health Icon Award 2021, awardee of Women Medical Professional Award. So she has got many accolades to her credit, and she is a member of many associations. She'd been the ex-president of so many associations. Actually, she has got many organizational position also. And Madam is a wonderful person, a very lovable person and friendly. So Madam, I welcome you. And Dr. Ankita, the next co-moderator is Dr. Ankita, who is MCH resident, reproductive medicine and surgical, Amrita Institute of Medical Sciences, Kochi, and she's awarded with Suffolk Young Gynecologist Award 2023 and web editor AOGD. She had been in 2021 trained in microvascular surgery, MAMC gynecologist for Aghaz Theatre Group, and she has got many awards. She is a very young and vibrant gynecologist, upcoming Foxian. So, and a very and a simple member of ISOPAB. So I welcome both of you, and over to you for the moderation. We have got the panelists. You can introduce the panelists, Ankita or Dr. Mala.
Thank you, ma'am. We invite Dr. Padmalaya Thakur. Ma'am is Associate Professor, Center of Human Reproduction, Some Hospital. She has special interest in reproductive medicine and is affiliated to IFS, ISAR, FOXY, and ISOPAB. Welcome, ma'am. We are esteemed to have you here. Dr. Anju Parira. Ma'am is President, ISOPAB Bokaro Chapter and past Vice President, Secretary, and Treasurer of Bokaro Obs and Gynae Society. Ma'am is also Director and Senior Consultant at Mother Care Hospital. She has various awards and honors to her name. Welcome, ma'am. Dr. Sangeeta Singhal. Ma'am is President, ISOPAB Jamshedpur, ex-HOD Department of Obs and Gynae, Tata Main Hospital, Jamshedpur, and past President, Jamshedpur Obs and Gynae Society. Welcome, ma'am, today. Dr. Jayoti Malhotra, ma'am, Senior Consultant at Kurji Holy Hospital, Patna, Secretary ISOPAB, Secretary PARB, Chairperson POGS, Practical Obs and Gynae Committee, and active member of ISOPAB. She has presented papers in state and national conferences with special interest in high-risk pregnancy. Welcome, ma'am. And Dr. Ruchika Garg, ma'am. Ma'am is Professor, Department of Obs and Gynae, SN Medical College, Agra, Editor-in-Chief, Journal of Suffolk, as well as various awards to her name, like Corion Award Senior Category 2021 and in Junior Category in 2019. She has a Foxy Future Award North Zone, Foxy Star Award, Jagdishwari Mishra Award, to name a few. Welcome, ma'am.
Thank you, Ankita.
Good evening, everyone. It's my pleasure and privilege to conduct this panel discussion. We straight away go to the cases because everybody is interested in case-based discussions, and which are very practical problems that we face in day-to-day life. So I begin with the case one. A young couple, female 26-year-old, husband 28 years old, married for 1.5 years, presents with inability to conceive.
Ma'am, your screen is not visible. Yeah.
Yeah. Now, can you see the screen?
Yes.
So we have an esteemed and very experienced panelist. So I request Dr. Padmalaya, what important points and history is important for in this patient?
Good evening, ma'am. In this case, yeah, they have married for 1.5 years, but I would like to know the trying period, and then from how many, what is the duration of they are trying to conceive? Are they aware of this fertility?
Trying period is 1.5 years.
Yeah, but and is there any history of any contraception use? They are aware of this fertile period or not? Is there any sexual dysfunction like this loss of libido, erectile dysfunction, or any problem with their coital frequency? I would like to know. Then coming to individually from the female, I would like to know detail about this menstrual cycle. Is it regular or not? Is there associated with any pain or any heavy menstrual bleeding? Then any past medical or surgical history that can affect the fertility of the female, like any presence of any chronic illness like diabetes, hypertension, hypothyroidism, any surgery, pelvic surgery, history of any pelvic infection from the female, and if there is any for male also same, any presence of any chronic illness or any surgical history, specifically any hernia, hydrocele, or any surgery related to the reproductive tract. Then I would like to know about this occupation of the male, presence of any alcohol or nicotine abuse. That's all will be from my clinical history taking, ma'am.
No, so basically we have to find out the cause of infertility in these patients. So from the history, we are trying to gather whether she's ovulating properly or not. And then what important investigations to be done, Dr. Anju? Can you throw a light on the important investigations that we want to do for this patient?
Good evening, ma'am. For this patient, after knowing the detailed history and doing examination, we will go for the investigation that she has any hormonal dysfunction of thyroid disorder. So serum TSH we will do. And general investigation, also knowing the status of hemoglobin, whether she is anemic or not. And then in this case, we will do this baseline pelvic ultrasound for lady, and husband semen analysis we will do.
So we will do the husband semen analysis. From the history, we are trying to gather whether she's ovulating regularly or not. And the investigations, baseline hormone test that we'll do. What investigations, like what hormone test would you like to do for this patient?
Serum TSH and this serum prolactin. We will elicit whether she has any galactoria or not. Only then prolactin will be subjected, and diabetes should be ruled out. Fasting sugar and oral glucose tolerance test, this will be done.
And would you like to do some tests to know the ovarian reserve as well? Because we are doing investigating her. The
For ovarian
investigation, blood test, FSH, AMH,
serum
all
FSH
this.
and serum AMH, and for subject to ultrasound baseline to know the antral follicle count.
Okay. And then we can ask Dr. Sangeeta, madam, what approach and what counseling are going to do for this particular patient?
So we have discussed till now that how we are going to take the history and investigation, and now we come to some conclusion what exactly we are dealing with this particular case. So the approach is to basically, I'll say that as we discussed that we are going to have a minimal investigations. It has to be more focused and very cost-effective way of investigating this patient, not any interventional method we will like to do right now. And we will counsel both the partners and tell them about what exactly is the fertility period, because we have seen many times that these patients, they try to conceive, but they are not aware about their fertility period, and that window many times they miss, because most of the time the coital frequency is not adequate and they miss many times. But if we are finding anything special, like if we are thinking in terms of PCOS, where their lifestyle management is not up to the point, so we'll counsel about their diet and exercise, which Dr. Lakshmi has explained so well just now. So we will counsel about that. But the most important, because they are young couple, we have to counsel them about their fertility duration, fertility timing, and fertility window, so that they can do a proper intercourse at that particular time. And at the same time, we will ask them to have their lifestyle modification if there is any changes with their need. especially their use of smoking, alcohol intake, any recreational drugs if they are using. So all these things, they should be counseled to reduce all these things, and so that the chances of conception will be more.
So Dr. Joyati, now this couple, would you like to do HSG in all cases? Dr. Joyati? Hello, Dr. Joyati? Hello, am I audible?
Yeah, you are. Yes, we can hear you.
Yes,
I
ma'am.
think Dr. Joyati is not there.
I'll just call her up.
Dr. Ruchika.
Hello? Yeah, HSG can.
Dr. Ruchika,
According
can you
to
take up? Do you do HSG in all cases? Oh yeah, Dr.
Hello,
Joyati is here.
Yeah, she's
You do
there.
HSG in all cases?
Yeah, Madam, HSG basically we need to do it definitely, not in all cases, but definitely we need to, before we do ovulation induction, we would need to know that the tubes are patent, because otherwise there's no point like giving. Suppose the patient has the block tubes, then there's no point in giving. So I usually offer them HSG, and of course, I think it is beneficial also because it's not that invasive also. Simple test, cost effective, and a lot of information also we get. So I don't think like it should not be done in all cases. I think we should do it.
So, Dr. Ruchika,
Yeah.
do you want to do ovulation induction in this particular case, or you want to do IUI in this particular case?
Yeah, if from the history, if we are able to know that her menstrual cycles are irregular and she has anovulatory cycles, because this has not been mentioned in the case, then because 1.5 years has already passed, we should go for ovulation induction along with follicular monitoring. Because patient also doesn't want to, they also want results, and 1.5 year has already passed. So we should start treating her with ovulation induction in case when we come to know that she is having anovulatory cycles. From the history, I would also like to know that how are her cycles, whether they are regular, or what is the cycle length.
No, this particular patient, she has taken the history. Dr. Padmalaya has taken the history that her cycles were regular. So still you would like to do ovulation induction, follicle monitoring, and IUI?
No, then we can wait for 3 months. Till we...
And if she doesn't conceive in next 3 months, what will you do?
Then we should, if she comes into the range of unexplained infertility, then we can always start with ovulation induction, and or if she is having documented anovulation.
So this patient comes under the unexplained infertility. Do you want to do diagnostic laparoscopy in this particular patient?
No, for diagnostic laparoscopy, we can wait. We will wait for the results.
Unexplained infertility, do you want to do diagnostic laparoscopy?
Ma'am, we will explain all the things to the patient, and diagnostic laparoscopy can be planned. It depends on the patient's choices also.
Madam, we can do diagnostic laparoscopy if it is unexplained.
So, Ankita, can you sum up? Dr. Ankita, can you sum up?
Though she is a young couple.
So in this patient, we'll start with the fertility history. The history needs to be taken because we have to understand what is the timing where they're trying for pregnancy. And if a patient in this particular case, she's a young patient, so we can wait before we start with the fertility evaluation for 1 year. But if she was more than 35 years, we should have started with 6 months. We have to take a proper history length and timing of intercourse, coital frequency needs to be elicited. And also we need to rule out if there are any sexual dysfunctions. And also we have to elicit if he has ever had a prior conception. Gynecological history will include the menstrual history with the cycle length, whether the cycles are regular or not, and if there's any dysmenorrhea or dyspareunia, to rule out any minimal endometriosis, which may not be evident on the ultrasound. We have to rule out the infections, as well as we have to see if there was any contraceptive being used in the recent past. Any medical surgical history needs to be elicited, because any history of pelvic surgeries will compromise the ovarian reserve. Any medications that she was taking in the past have to be documented, and a routine family history has to be elicited along with the habitual history as well. And male history is very, very important. We have to see any surgical medical conditions, history of drug, alcohol use, and any sexual dysfunctions. Also, we have to do a semen analysis at the first visit. Thyroid examination needs to be done. Breast examination needs to be done. A speculum and a PV examination needs to be done to rule out any polyps or any erosions or any other problems. Plus, now we go on for the fertility evaluation in terms of ovulation monitoring, ovulation reserve, ovarian reserve needs to be checked, AMH, annual follicular count, and the baseline FSH and estradiol levels can be done as well. As already stated, the TSH, the prolactin levels have to be done. If there is any hirsutism, then even the androgen levels checked. A baseline transvaginal ultrasound done. If there is no tubal documented and 3 cycles have already gone, 3 cycles of IUI have been tried, then we can go on for an SSG to see if the tubal patency is there. But if there was a case of secondary infertility, then tubal patency has to be done earlier. Or if there's a history, high risk for a tubal block, like an endometriosis or an infection, then we have to go in for tubal patency tests at an earlier stage. All these tests don't need to be done routinely, but in case we see a symptom, then we can order these mentioned investigations. Male examination is very, very important. And these are the changes in the recent WHO characteristics of analysis. Semen analysis needs to be done at the first setting, so we don't miss anything.
So we have nicely summed up this case. Now we move on to the second case. Second case is a young married professional. Professional, wife 33 years, BMI 28, husband 33 years, BMI 27, presents with inability to conceive. They are married for 5 years, had MTP 4.5 years back. The girl has put on weight recently, trying for conception since last 6 months. She is also complaining of irregular cycles recently. So again, maybe request Dr. Anju, what important points in the history we have to take?
In the history, we will see the, first of all, age more than 30, 33 year around. And her BMI is also on the higher side. It is 28 kg per meter square. So now in history, menstrual cycle is very much important. And recently it is going irregular, and she's in the oligomenorrhea state. And there is history of one abortion is there. So we will look for any evidence of infection, although it is 4.5 years ago. So important the history of abortion. And now we will also, again, the thorough history will be taken regarding the menstrual history, previous obstetric history, any past medical and surgical history. Then in the male partner history is also important regarding occupation, regarding addiction and habit forming history. These all things are taken in the history especially. her cycle is showing that maybe she is now in the phase of anovulation. So detailed history should be taken.
So, Dr. Sangeeta, how long can she try in this manner?
So by this history, we have come to know that most likely she is a case of PCOS with increasing weight, irregular cycles, infertility with increased BMI. So in this case, we are going to start the treatment after investigating the basic investigations which we have already learned about the PCOS, and we are going to do ovulation induction in this particular case. And the way we have done the method of ovulation induction, we have already discussed, and we can continue for 3 to 6 months, this 6 months of ovulation induction with the first line of therapy. If they do not respond to the first line therapy, we go for the second line treatment, and even with the second line treatment for the next 3 to 6 months, we should go for the next for management, that is IVF or HCG. So this is the the way of treatment, and we cannot, because already she is 33 years with this PCO. I think we will not wait for a very long time in this case.
See, Dr. Sangeeta, while we evaluating her hormone profile, do we do HSG in her case as well?
I think because she has a history of MTP, which was done 4.5 years back, we do not know if she had any infection, any pelvic infection after that. But since she is trying to conceive, we can go ahead with tubal testing, because we have to know about her tubal status as well. So I think we can go for HSG in this particular case.
Dr. Joyati, would you like to do diagnostic laparoscopy for tubal testing, or would you be satisfied with HSG in her case, in this particular case? Hello? Dr. Joyati? Dr. Joyati? I think our internet connection is not very good.
Yeah, I think so.
Dr. Joyati?
Dr. Jyoti Malhotra? She's not. Okay.
Dr. Ruchika, would you like to do diagnostic laparoscopy in her case, or you will be satisfied with HSG
Considering
in her
the
case?
tubal factor, if we get an HSG report, so we will come to know about tubal factor. But if we are thinking for laparoscopic ovarian drilling for PCOS, though it's a second line management, we can also go for diagnostic but it's in this case, it's clearly a ovulatory dysfunction. So we can be satisfied with HSG itself. Clear cut, it's a no. But as Dr. Sangeeta has already told that she has undergone MTP 4.5 years back, so she might be having infection. So there is no harm if we go for diagnostic lab, and in the meantime, we can also go for ovarian drilling. Though laparoscopic ovarian drilling ke baad bhi AMH levels, they fall. We have to tell everything to the patient.
So we have to counsel the regarding the plus and minus points, can do the diagnosis as well as the treatment in this particular case. Dr. Padmalaya, whether you would like to offer her IVF because she is 33-year-old, do you think
No, ma'am, I
you
will
will
not
be
directly
very... No,
No,
not
ma'am,
directly.
because
After
no,
waiting
I
for
will
3
not go
months.
for means we can start with the ovulation induction, because she has never received any treatment, and they have tried only for 6 months. We can we can go with step by step. Initially, I will go with the first line treatment. As we all know, letrozole is a drug of choice now because of its positive impact along with monofollicular development. There is also good effect on the endometrium in the cervix. I will go with letrozole. Ovulation induction with letrozole, and with start from the low dose 2.5, then 5, or even in our center we are also going up to 7.5. and I will do serial follicular monitoring to which dose she is responding, and I will give minimum 3 to 4 cycles of the particular dose what she has responded.
So we will not jump into IVF in this particular case. We will ask in a step-by-step lifestyle modification, and then we will impress the importance of diet, exercise, then comes some medicines, and of course, fertile period. If all this does not work, then of course we can offer them, if they are not ovulating properly, then we can offer them ovulation induction, as well as if that also doesn't work, give ovarian drilling. As Dr. Ruchika said, that we have the advantage of taking laparoscopy and doing ovarian drilling as a treatment of PCOS. And definitely if nothing works and the couple is very anxious, we can also think of IVF. What do you think, Dr. Ankita?
Yes, it has been summarized slide that after lifestyle, the first line is lifestyle modification. And if she has not responded, then we may go in for ovulation induction. First line being letrozole or clomiphene citrate. Letrozole is being preferred as it is agonistic at the endometrium as well and is giving us monofollicular development. And if she's ovulating, then we may try for 6 to 9 cycles. If, however, she's not ovulating, we may go in for second line therapy, which is either gonadotropins or clomiphene citrate with metformin. Or if she has a high AMH, or if the LH levels are high, or if in ultrasound we see that the stromal thickness is too much, and if she's having a resistant PCOS, then we can go in for PCOS. In PCOS patients, we can go in for a laparoscopic ovarian drilling. After having counseled the patient that there is a risk of loss of ovarian stroma and also there is loss of ovarian function after laparoscopic ovarian drilling. But patients are known to ovulate and to naturally conceive after laparoscopic ovarian drilling. And when we see the cost of gonadotropins along with, when we measure it along with laparoscopic ovarian diathermy, the result live birth rate may be similar. So we have to counsel and then go ahead. And IVF, going for an antagonist protocol, because we want, as already discussed, we all want an OHSS free clinic because we have a high risk of OHSS in these patients in PCOS. So we may go for an antagonist protocol.
You have nicely summarized, Dr. Ankita. Now we have the third case in line. Young married couple, wife 31 years, BMI 26, husband 31 years, BMI 26, married for 3 years, not living in the same city due to job profile, trying for conception for last 1 year. So again, Dr. Sangeeta, what important points in history is important?
Yeah, in this case, I think we are not aware about their menstrual cycle because they are staying in a different places. How frequently, what is their coital frequency, that also we do not know. We are not aware about their other medical, past medical, surgical, previous obstetric history, if there is any contraceptive history. So we'll take all this history and we will try to find out whether she belongs to any of these high risk category like PCOS, endometriosis, adenomyosis. And if we have to rule out all this thing by the detailed history of both male and female partner. And even for the male partner, we have to take the full history. If there is any history of previous fever, mumps with orchitis in the male partner, or any history of diabetes, hypertension, thyroid in both the partners, because they are job professionals staying in a different part. So the stress level may be very high. We do not know what is their lifestyle. So we have to see all these things and to exclude all this diabetes, hypertension, thyroid, and any other pelvic infection, tuberculosis, all these things we have to exclude and do the baseline investigations, especially TSH, prolactin, if there is some breast discharge or breast tenderness, and ovarian reserve, as we discussed in the previous two cases as well. So we like to come to the basic history and investigation for this particular case, and we have to do a thorough and a baseline pelvic ultrasonography to see their antral follicle count, their ovulation, and the semen examination of the husband, which is the must. And these are the basic things which you have to do.
Dr. Ruchika, how will you counsel her?
So we have to tell her about the fertile period. Most of the time, the patient, like this couple, they are staying apart and they might be meeting in the
room में जाकर लगवा ले.
sterile safe period में मिलते होंगे. So, and also about the lifestyle changes, we have to tell them. Her BMI is also in the higher range. It's 26. And in these patients, we can try for ovulation induction along with IUI so that the cycle is in our control. And
because
also,
they can also time, because they get lesser
timed
time
intercourse
with them.
can be,
they have to plan things. So we can try ovulation induction in this particular couple at a slightly earlier stage. And maybe we can also try IUI in this particular case. Dr. Padmalaya, how long can we try IUI in this particular couple?
Ideally, 3 to 4 cycles, maximum 3 cycles. Because they are not staying together. So IUI is a good option. And we can go for 3 to 4 cycles.
Yeah, you don't want to go more than 4 cycles.
3,
because
more than 3 to 4, not
the couples are fine and they are normal. So cycle itself, because maybe the other profiles are normal, only that they are not getting time to stay together. Do you still want to do HSG or diagnostic laparoscopy in this particular case? Or you can straight away go to ovulation induction, IUI in this particular couple?
Before IUI, I must establish that the tubes are patent. And after taking the proper history and examination only, I can decide either I will go for HSG or diagnostic lab. If I will suspect anything like any previous STD or any suction evacuation, any history of something suggestive that I may get some tubal pathology, then only I will go for diagnostic lab. Otherwise, I can do one HSC and I can go for IUI, because from the history I can clearly it is seen that because of their job, professional life, and because of the unavailability of the couples during their fertile period, that may be the major cause. And go tubal patency test with HSG followed by IUI if the tubes will be patent.
Yeah, in this particular couple, maybe IUI will be a better option for them. Dr. Ankita, can you sum up the case?
Since they are living apart, we have to first take a proper history to rule out any risk factors. We also have to make sure that we know about the age, menstrual history, any previous pregnancies, any history of abortions, infections, and then we have to time the cycle. We have to do regular follicular monitoring. If she's staying away at wherever she's staying, she can get her ultrasounds done to monitor if she's ovulating naturally. Sometimes if she's not ovulating, then we may give ovulation induction at an earlier stage. But if she is ovulating, natural conception can be tried with planned visits during the fertile period. Also, we can go in for a modified natural cycle where an HCG trigger is given when the size of the follicle is reached at an adequate size, and we can also time the IUI along with it, or the husband's visit with time cycle can be timed accordingly. If we take a careful history and the length of our cycles, we can also time it such that in one visit, two cycles of IUI can be given in a month visit. We can plan it such So that is how we can track and plan the cycles. Ovulation induction with IUI can be done after doing a thorough tubal patency test and an ultrasound along with the semen analysis. And if all else fails, then we may go in for an IVF. Also, IUI can be done with a cryopreserved semen sample if the husband is not able to visit. Otherwise, IVF can be an option for them.
I think we have discussed all these cases which are common scenario in nowadays practice, professional couples, job-oriented, busy life, and then we have to counsel them about the lifestyle modifications. And I'm happy that all my esteemed panelists had given great inputs to discuss these 3 case scenarios. And I must thank Dr. Lakshmi and Dr. Supriya, who had given us this opportunity to moderate this session this evening. Thanks, everyone. And I'm happy that we had been able to discuss all the cases. Nice.
Thank you, ma'am. Thank you, Ankita,
Over to you,
for
Dr. Supriya.
upcoming smart doctor.
Thank you so much. Thank you so much. It
Yeah.
was a wonderful panel discussion, and Dr. Mala, you had been a really great moderator. And
No, we
Dr.
wanted
you
all your
summarized
inputs.
so well.
Yeah, because each and every one is a senior practitioner, and we wanted your inputs and how do you have your practice guidelines.
Thank you so much. It was really wonderful. And thank you, Dr. Lakshmi and Dr. Supriya, for giving us this
Having
opportunity.
all of us here.
Sangeeta,
Thank
just
you.
if you are here, please, would you like to give some comments on these 3 cases? I mean, how you managed there and how we managed here. Yeah.
Definitely.
Yourself, yeah.
Sorry. Yeah.
I could add a comment. Thank you very much for the cases and case discussions. We do exactly the same. So it is great to see how we do protocols and how we treat our patients doesn't differ from a country to another. And it was a fruitful discussion. Thank you so much.
Thank you, Elif. Thank you so much for staying till the end of the program. Thank you.
Basically, scenario all over the
It
world
was
is
a
almost the
wonderful
same.
webinar.
Yeah,
And all of
basically,
you did
we
so
all are
well.
going through lifestyle
And
changes.
congratulations. Thank you very much.
Yeah. We all are having the same problem all over the world. Young couple, they do not plan pregnancies early, but when they plan pregnancy, they want it within 1 or 2 months.
Yes.
The important thing is that we have to explain to the couple that they will take some time. Even when they're planning pregnancy, they will take some time to conceive. After marriage, 3 years, they will not plan. And once they start planning, within 2 months, they want to get pregnant. This is the scenario all over the world. And I'm sure, Dr. Lakshmi, you must be facing the same problem.
Same.
In day-to-day
Instant. In the same month,
Ma'am,
they should become.
in
Yes.
our rural area, within 6 months, the ladies want pregnancy. That's the different scenario. And if we don't give ovulation induction, they will change the doctor.
Yes.
And as a result, they keep taking ovulation induction for years. They keep changing the doctor and they will not tell the
Yeah,
past.
and taking the same ovulation induction for you.
They will not show the old file, old papers. That is sad. Yes. So thank you all. Supriya, now you can
Yeah.
officially go ahead with your vote of thanks.
Yes, madam. So thank you so much. The panel was very interesting because Dr. Mala, you presented it in a very different way, actually. And Dr. Ankita, really, you have done wonders. And
Thank
all
you,
the
ma'am.
panelists. Yeah. So I just to propose the vote of thanks, it is since it was the 5th series of the Seed to Bloom series. So I really thank, first of all, the person behind the scene, the Dr. Lakshmi Shikhande madam. She's really chosen a very nice subject for this series also. That was interactive, very, very useful for all of us. And we had A to Z of PCOS actually, I mean, and infertility. So it was wonderful. Both the talks and the panel covered everything. So thank you, Lakshmi ma'am, and thank you for having so much trust in me. Thank you so much. Then our national president, Dr. Arup Kumar Manjhi sir, he gave his all words of blessings. Pragya Di in Secretary General, she couldn't join yesterday. She had come from there and must be engaged somewhere. And thank you, Sulekha Madam, for being the chief guest, agreeing to be the chief guest. And before time, she took the faculty link and everything. She's very, very prompt in coming to the webinars, and she doesn't want to be a dropout or something. She is very active member of ISOPAP, and rightly said, she goes to all the conferences in spite of her certain health issues sometimes if she faces some health issues. So thank you so much, madam. Thank you. And Dr. Hiralal Konar sir, for the guest of honor. You are a wonderful person. Thank you so much. And you have inspired all of us by your words of blessings. Then
Supriya, I have attended whole of the session.
Yes.
So
thank
it's
you
good.
so
Yeah. I was silently listening to all the discussions up to that of the Mala Srivastava, the beautiful that of the panel discussion.
Yes.
Nice, difficult
So-
topic, well discussed, well covered, extensively covered. For all of us, it would be a refreshing of our understanding and knowledge. Lakshmi has talked about the detail of the ovulation methods and things, and our international delegate has given us the lots of information, especially that I love that of the genetic background of the problem.
Yes, sir. So
This is the
thank you
current
so much.
current scenario now.
Yes.
I have
So
enjoyed.
thank you, sir, for your inputs and being till the end of the program. So thank you so much. And I really thank our wonderful speaker, the international speaker, Dr. Elif, for staying on throughout, logging in first, and still you stayed to the last to be the expert in the panel itself. So thank you so much. I thank Lakshmi Madam for the wonderful talk. I already told you, Madam, you covered everything in your presentation. The wonderful chairpersons who had wonderful interactions, Dr. Himali Sinha, Dr. Anupam Gupta, Dr. Sanjukta Mahapatra Madam. She was also very prompt in joining, Dr. Tapan. All of you did wonderful discussion and inputs from the speakers and the audience. And then Dr. Mala Srivastava and Dr. Ankita, wonderful panel discussion, moderation of this panel. Then Dr. Padmalaya Thakur, Dr. Anju, Dr. Sangeeta, Dr. Jyoti Malhotra, and Dr. Ruchika. The panelists were excellent. So the whole program was very good. And thank you, Shield Connect, Chitrakala, and Sahiti. They really helped us do the program so well, Lakshmi ma'am. They really help us a lot, changing the flyers, making the flyers, and the flow of event. Thank you so much. Thank you, the audience who have listened to the whole program. Thank you, everyone.
And thank you to Supriya for wonderful coordination and conduct.
Yes, that's true.
So well.
Thank you, ma'am.
Without you, Supriya, this program would not have materialized. So thank you so
She
much.
has made the all communications, coordination, all the speakers, all these guest of honors, everybody.